I'm representing the AGBI on the project, and also would like to acknowledge Audrey Quinn and Ravi Mahajan for the training section, and I would also like to acknowledge David Buggins and for the organisation element. Okay, a lot of this is going to be repeated. You've seen the themes that came up today, and you will see that as we go through. So in total, 80 events were recognised in which education and training. So almost half education and training was a contributory factor. These are some of the training elements that came through. The location, we've heard that from Jane this morning, the intensive care unit. There's an element there of maybe an absence of training of to maybe ODP level. The junior trainee anaesthetist. Junior trainees is involved, they tend to be a worse outcome. And then the patient factors, obesity is a big thing that is coming through. Have we got the right education on obesity? And there, strangely enough, gastrointestinal obstruction and aspiration, still in this day and age perhaps. And then some of the tax factors we've heard in detail about poor assessments, poor planning, the lack of capnography, and the interpretation of capnography has been a big part. And again, the appropriate use of laryngeal masks and the uses of respiratory factors. And then team factors you'll hear from Jan Shaw after I finish. So we have a curriculum, we have competency-based training, we have a level from basic level through to advanced level. Is it fit for purpose? Hopefully this project will now tease out things that perhaps we need to expand our competency of training. And we're very familiar with this CPD matrix, and there they are, the airway assessments, the basic airway management, the can't intubate, can't ventilate, caused that interesting controversy in the last speaker. Human factors in anaesthetic practice, it's all there. This project will hopefully drive us forward to improve these areas. So training in anaesthesia, I'm going to pick on the various bits that we've heard this morning. Airway management was considered by the review panel to be poor in a high number of cases. The review panel considered that most of the common contributory factors were patient factors, poor judgment and education and training. Poor judgment, education and training, are they interchangeable? Is that judgment factors perhaps, because as we've heard from Nick this morning, these are rare events, although we know they're going to happen to you in 1 or 3 years' time. How can you practice these rare events? It's surprising that formal adoption of difficult airway society guidelines is not universal. Either the guideline wasn't there, the guideline was not used, or it was used not completely. We heard a little bit about recovery, and I think I picked on this because it's that Cinderella area. So 38 of those 133 reports from anaesthesia, that's almost a quarter associated with anaesthesia with airway complications, emergence or a recovery period. This late detection of airway problems, and we don't have this agreed national standard. And the AGBI, hopefully in June, David Whittaker in the front here is the chair of that working party, is going to bring this post-anaesthetic care document out. Recovery room staff should be trained to an agreed standard. And that must be in all hospital sites, whether it be obstetric units, increasingly your gastroenterologists and your radiologists using sedation, that should have the same standard. And this must include prevention and early recognition and management of airway destruction. And how do you deliver that? How do you train those individuals? So the project highlighted, this is a direct quote from it, the importance of involving simulation centres, human factors experts and trainers from different disciplines enhancing training. There you have a high fidelity wireless version in our hospital, actually in the anaesthetic department with ODPs, nurse anaesthetists and trainees. Again, that could be used in recovery, emergency departments. How else are we going to train on these rare events other than using simulation? But we have to be cautious. In the BGA postgraduate issue of last year, Cumming et al. Suggested we need standards. And these standards must be set so that we can create confidence in using these tools. So a training summary that maybe highlights some of the areas which we need to expand in our core curriculum and in our CPD. So this assessment of risk and impending airway destruction, regurgitation and aspiration. It's a theme that's been with you this morning, and we need to have those planned out. The appropriate use of supraglottic airway. We heard again this morning about how those airway needs just as much training, if not more, than intubation. This care of the tracheostomy and intubation patients in intensive care. Again, it must be a training element, not only for the doctors on that particular unit, but also the nursing staff and those taking care for that 24-hour period, which is a difficult period. Capnography has been a great theme throughout this morning, and again, it's not only its use, which we're advocating, but obviously there must be more emphasis on the interpretation of those echocardiographic traces. Great debate on cricothyroid puncture. Where do we go from here? What, is this what Mike Grucock may be taken on as part of the research element of this? Is it a training issue? Is it the kit? We had that great debate before lunch. We don't have the answers. And maybe this other rescue device, this intubation through the supraglottic airway, again should be emphasised in our training programmes. Certainly the strategic planning and the dealing with the difficult airways that Adrian was talking about is deficient in a lot of the training programmes, and perhaps this is another training element that we need to pick up on. And certainly, as Jan will take up in the next talk, human factors and including non-technical skills to help communication and teamwork together. So the organisation element, 72% from anaesthesia setting, 20% from ICU, 8% from emergency department. We've heard 3 cases involved in transit. We've heard cases involved in radiology. An organisation needs to be prepared for difficult intubations and airway problems throughout its departments. After review of the NAP4 report, organisational factors are judged contributing in almost 23%. So what are these organisations, what are these system errors which we found? We shared this morning about equipment shortages, inadequate maintenance, kits falling apart. We've all faced this, incompatible goals, that drive to get the theatres more efficient, that conflict between the clinical need and finances, day of surgery admission. Reluctance to understand what went wrong and form analysis of adverse events. You have vignettes in the chapters about the loss of documentation, the unavailability of pre-op notes, the lack of communication of those difficult airways, and this breakdown in communication not only between anaesthetists but within teams, so that there isn't a proper discussion of the intended plans of action. Inexperienced personnel working unsupervised. Although a lot of consultants were involved in these events, there were still some times where inexperienced personnel were working. This lack of time to undertake a thorough assessment, not a complete assessment. No use of further investigations where further investigations would have been helpful. No scheduled training sessions for updating staff in the use of new equipment or new techniques. And this incomplete or inadequate briefing handovers, and perhaps poor or non-existing debriefing. This is a paper that came out in 2005 from Roll et al. In clinical anesthesiology, where they tried to put some of the modern safety culture, and they call it crisis resource management, maybe better understood as crew resource management, into area management. Area management, they say, is the cornerstone of patient safety in anesthesiology. Of course it is, that's our main business. And obviously, and we've heard from Jonathan and Jane this morning about the problems of area management in emergency and critical care medicine. This concept of high reliability organisations, like the oil industry, although they had their problems in the Gulf of Mexico, now ready to adapt to medicine. And this use of some of the key elements of crew resource management, which Jan will probably go into, and the development of a checklist. We had that question about the checklist, and there it is, and there it is highlighted. This has been given to us. This is our opportunity to engage in that discussion. Difficult airway, we can involve the team, immunosurgeons, right at the start. We have this sign in, but it should be done right at the beginning. This is the final slide I'm putting together of what a patient safety programme should be. So we have the education element, which we teased out a little bit. Team training, so vital, highlighted in that pit and recovery. The innovations and some lessons learned, this is what we're all here today. We've got to put this into practice. We've got to keep the reporting of the data and the collection, and hopefully we will not lose the anaesthesia-specific part of the NRLS with the coalition cuts. Research and development, Mike will deal with that as we go later, and sharing these problems that we all have. And with that, we'll hopefully get the pros improvement, and perhaps the holy grail of culture of safety will be achieved. This project hopefully will go somewhere to deliver that culture of safety. Thank you very much.